Hello and welcome. My name is Joe Caramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. And thank you for joining today's Grand Rounds presentation. A couple of things about our Grand Round series for this academic year. We're trying to have many to most presentations focusing on a theme called Next Steps in Care. And I think that's happening with today's presentation about sort of up-to-date information about assessment and treatment in adolescent and young adult depression. Now there's a core team, a group of us that works on Grand Rounds each week, including Samhara Braha on coordination and communication, and Mike Walker on technology. We archive our presentations at the Grand Rounds website, where you can watch past presentations. Funding for this year's series is from the Ripley Fund and from institutes in the department, such as the Garvey Institute for Brain Health Solutions. Towards the end of today's presentation, I'll put a link in the chat for participants to complete a brief 5-question Grand Rounds presentation evaluation. And that information is helpful for me to communicate with presenters afterwards. Also, please write any questions or comments into the chat, and I can go through those with Dr. Miller at the end today. And now for today's presenter, Dr. Leslie Miller. Dr. Miller is an associate professor of clinical psychiatry in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. And just a brief background. Dr. Miller completed initially general adult psychiatry residency training at Mount Sinai School of Medicine, followed by 2 fellowships at Johns Hopkins. First, a clinical fellowship in child and adolescent psychiatry, followed by a T32 funded research fellowship, specifically in child and adolescent psychiatry. Dr. Miller then continued clinical research and was awarded a K-23 grant from NIMH to evaluate interpersonal psychotherapy in youth with mood dysregulation. And since then, Dr. Miller has developed and is now director of the Mood Disorders in Adolescent and Young Adults program, which includes a multidisciplinary assessment and treatment approach to adolescents with mood dysregulation or mood disorders. Dr. Miller is a member of the Miller-Colson Academy of Clinical Excellence and had received at Johns Hopkins the inaugural Dean's Clinical Excellence Award for Excellence in Service and Professionalism. Now today we'll learn updates on best practices in assessment and of young adults and adolescents with depression, and ideas about next steps in clinical research. And now I'll turn it over to Dr. Miller.
Thank you very much. All right, let me share my screen. Okay, thumbs up, Joe. Are we good?
Yes,
okay,
that's good.
You. Okay, so thank you so much for inviting me today. I'm really honored to present on adolescent depression. So first, of course, I'll just mention my disclosures. I have research funding from the organizations listed, and I will discuss off-label use of antidepressant treatments in youth. I'm hoping by the end you will understand the differences in adolescent compared to adult depression and familiarize yourself with treatment strategies for adolescent depression, including treatment-resistant depression. I will go over some epidemiology of adolescent depression and then treatment, talking about pharmacotherapy and psychotherapy, and then touch on future directions. So in terms of epidemiology, data from the National Comorbidity Survey study show us that we have a lifetime prevalence of major depressive disorder in 13 to 18-year-olds of 11%, with a 12-month prevalence of 7.5%. Adolescent females and older adolescents have both higher rates and more severe episodes of depression. Data from the National Survey on Drug Use in Health from 2005 to 2014 looked at 12-month prevalence rates, and they found that adolescent depression increased from 8.7% to 11.3%, whereas young adult prevalence rates increased, but not as much, from 8.8% to 9.6%. But the most significant increase was from 12 to 20-year-olds. And if we look at familial patterns of heredity, Myrna Weissman and colleagues looked at multi-generational patterns of depression and found children with depressed parents and grandparents had higher rates of depression than those with children or grandparents alone with depression. Risk factors for adolescent depression are being female, having a family history of depression, a trauma history, chronic medical illness, family conflict, being a member of a sexual or gender minority group, or being a victim of bullying. In terms of the clinical course, from the National Comorbidity Survey, we see that an average episode length of depression is 27 weeks, and this was treated and non-treated combined. And when we think about this, that's about half of a school year. So really thinking about the impact in terms of schooling and academic functioning is pretty important to think about when it comes to adolescent depression. We also think of adolescence as a time for developing autonomy and independence, but if a youth is depressed for half of a year, it really impacts the attainment of these developmental milestones. These researchers also found that 63% of youth had a significant disability in at least one domain of functioning. Nearly 30% of those with a major depressive disorder reported some form of suicidality, with almost 11% reporting a suicide attempt. Of note, 60% of teens received treatment, but only a small proportion actually received depression-specific treatment, and it was less likely for those with mild to moderate depression. So data from the National Survey on Drug Use and Health looked at the proportion of adolescents and young adults receiving mental health treatment. And despite the increasing prevalence of adolescents with depression, the proportion of them receiving mental health treatment did not significantly change. There was an increase in young adults receiving mental health care or depression care. So we still see that there's gaps in treatment. So we're all familiar with suicide as the second leading cause of death in 10 to 25-year-olds. The trends we're seeing are increasing rates of female suicide due to increasing use of lethal means and increasing rates of pre-adolescent Black youth suicide. So we see on this chart, we can see it's split by age from 10 to 14-year-olds and 15 to 19-year-olds, and split by gender. Risk factors for youth suicide are having a mental health disorder, affective disorder being the most common, alcohol misuse in older teens and males, having a history of self-harm, difficulty managing strong mood fluctuations, poor problem-solving skills, dichotomous thinking, having a family history of depression, substance use disorder, or a history of suicide. Interpersonal stressors are also a risk factor for youth suicide, such as breakups, losses, or peer rejection. In terms of COVID, we've seen increase in ER visits for suicidality. And anecdotally, I've seen more suicide attempts on the inpatient unit since COVID, and we're waiting for data to see the impact in terms of whether or not there's more completed suicides. This slide is from my colleague, John Campo. It just highlights the impact of youth suicide. So teen and young adults. So in 10 to 27-year-olds, 10 to 24-year-olds, sorry, in 2017, if you look at the percentage of youth of suicide, it's more than all of those medical conditions combined, which is pretty striking. Next, I'm going to talk about the clinical presentation. We're all familiar with the criteria for major depressive disorder from the DSM-5, SIGI CAPS. The most notable distinction for pediatric depression is that the DSM-5 includes irritable mood as a possibility for the affective component rather than just sad mood alone. So though teens can present with any or all symptoms of pediatric depression, with all symptoms of depression, pediatric patients often present with appetite and sleep effects and loss of energy, whereas adults are more likely to present with anhedonia and difficulty with concentration. Therefore, when screening for adolescent depression, it's important to ask about changes in sleep, energy, and appetite. Interestingly, early in my career, we were always taught to assess for irritability, as that may be the presenting mood symptom. But more recent data looking at the most prominent mood symptom has found that irritability alone is not a hallmark of pediatric depression, which is something we used to think. Rather, sad mood is generally present with or without irritable affect. And irritability is a transdiagnostic symptom in pediatric mental health. We see it with anxiety, ADHD, DMDD, depression, and bipolar disorder. So when assessing for depression, it's really important to inquire about sad mood as well and other associated symptoms. So especially in the teen population, it's quite helpful to inquire about sleep patterns. So I ask teens, what time do you get in bed? What time do you fall asleep? What time do you wake up? What's the electronic usage before bedtime? Are they activated and having trouble falling asleep? Do they sleep with their phone? Are they woken up by text throughout the night? What is the total number of hours sleeping in a 24-hour period? Do they have awakenings? What is the number and duration? I write down a detailed description of sleep onset and duration and quality to assess for depressive symptoms, and then so I have specific information to track progress, worsening of symptoms, or medication effects during treatment. As those of you who work with teens may already know, they don't necessarily remember what they told you at a previous session. So when they say sleep is worse or better, I have the information to compare it to. It's also difficult to get teens to buy into changing their sleep habits. We ask them to monitor their sleep patterns and their mood to increase their awareness that poor sleep impacts their mood, especially in terms of irritability. I've worked with teens to write down the time they go to sleep and wake up and a mood rating so we can correlate sleep pattern with mood to increase the likelihood of sleep changes. In terms of assessing for concentration, it's important to really assess pre-depression academic performance. So in our high achieving teens, getting B's rather than A's can actually be an impact of depression. So we really want to know what pre-depression academic performance is. I also like to know the amount of time it takes them to complete their homework compared to peers. It takes them 4 hours and their peers 2 hours. That would be an impact, and compared to their pre-depression functioning. I also like to see if they have any difficulty with following the plot in a TV show or movie, or being able to retain the information from reading. Regarding anhedonia, I ask if they stop participating in clubs, teams, or sports, and how much they enjoy hanging out with their friends. Teens may often say that it's less enjoyable, or I enjoy it for the first 30 minutes and then I no longer enjoy it. So it's sometimes difficult for parents to understand that their child can be depressed yet still hang out with their friends. Next, I'm going to talk about treatment. So in general, I take a collaborative approach, really wanting everyone to be on the same page in terms of treatment planning. We discuss psychoeducation as a treatable medical illness. And then I look at the 3 domains of functioning to assess for severity. I want to see if there's impairment in family, school, and peer domains. And then the American Academy of Child and Adolescent Practice Parameters recommend for mild depression a trial of therapy, but regular assessments of symptoms. So if you need to change course, you're regularly assessing if symptoms are improving or worsening. For moderate depression, they recommend therapy plus minus medication. And for severe depression, they recommend combined treatment. So it can be challenging when parents and teens don't agree on treatment approach. We work very hard to come towards some agreement. For example, if a parent is not in favor of medication, we will discuss a trial of therapy, and if there's no improvement in 8 to 12 weeks, we meet again to discuss the plan. I have some parents who say they don't agree with medication, but will allow their teen to take medication if they want to. We explore parents' views on medication. Perhaps they had a bad experience or a family member did when younger, which could be influencing their decision. I like to have an open discussion about medication. I also regularly check in with parents during ongoing care. Sometimes parents are able to offer examples of improvement in mood that teens are less aware of, such as increased communication with parents and decreased isolation. We also include measurement-based care in our clinic with regular ongoing assessments. So in terms of pharmacotherapy, how do we decide? Our motto is low and slow. We take family history response to medication or side effects into consideration. We consider FDA approval, but it's not the only factor since only fluoxetine and escitalopram are approved for adolescent depression. Sertraline and duloxetine are approved for anxiety. And really, we want to make sure that it's understood that a trial is considered an optimal dose for 8 to 12 weeks. I often see teens that have been underdosed, even if they've had an adequate trial. And so really emphasizing that before we call something a failed trial. If there are side effects, we slow titration or switch to a different SSRI. Because we start low and slow, the length of time to get to a target dose can take longer than for adults. So we provide education about this aspect of care, but we do titrate to an optimal dose. And in terms of pharmacotherapy, it's really important to discuss expectations for taking medication. Daily for a minimum of 6 months, but really we prefer a year to decrease likelihood of recurrence. And then we also tell the team that they have to actually continue taking the medicine even when they feel better, which is sometimes hard for them to kind of wrap their head around. I also like to discuss with the team who will be responsible for remembering to take the medication, assuming there's no safety risk of overdose. If the parent will remind the teen or the teen will remember on their own, there are apps to help teens remember. I also have teens set reminders on their phone in session with me, or I problem solve with them. Do you need to put it by your toothbrush, by your book bag? How can we increase the likelihood of compliance? I also like to decrease the likelihood of arguments between parents and teens. So a lot of times the teen will perceive their parent as nagging them to remind them to take the medicine, and then they won't take the medicine just because they're annoyed by the nagging. So we really want to prevent that from happening. We also want to work toward increasing compliance for our older teens becoming young adults. So we sometimes have weekly pill boxes, and so the parent will then check to make sure that the pills were taken. We want to work towards autonomy and taking medication to prepare for college. We also want teens to be proactively taking control of treatment. So they make their appointments and they make the decisions in treatment and then let their parents know about the changes. We also want teens to be looking into mental health services at colleges to help for future planning. In our clinic, I'm lucky to have, I work with a therapist in team-based care. We work collaboratively together. We meet regularly as a team to review treatment progress, barriers to improvement, problem solving around those barriers. We offer evidence-based therapy, DBT, CBT, and IPT. We all speak the same language in terms of treatment, which is helpful to provide a unified approach to care. I'll talk more about this later, but part of that is my reinforcing therapy skills in session with teens. And the therapists discuss medication compliance, expectations about medication, and ask about side effects. As part of my discussion about medication, I present common and less concerning and less common but more concerning side effects. We're all familiar with the common and less concerning. In the pediatric population, something we also want to assess for and educate actively about is activation. It's more common in younger kids, but also can happen in teens. It's characterized by an increase in energy, insomnia, disinhibition, or restlessness. We usually lower the dose if this happens, or we may have to change the medicine if we're not able to. And then we also talk about the risk of mania or hypomania and the small but increased risk of suicidality. So we're all familiar with the FDA black box warning for suicidality. It was originally for pediatric patients and then extended to a young adult population. It was based on the original analysis, meta-analysis of 24 randomized controlled trials, 20 of which had data on suicidal events. And the data showed a 2% increased risk of drug compared to placebo. The next analysis by Bridge and colleagues included 27 trials and showed a risk difference of 0.7%. Importantly, though, the number needed to treat was 10 and the number needed to harm was 143. So more recently, so since the Bridge analysis, there's another analysis that included trials that were conducted afterwards. So there's 7 RCTs identified. And the difference is that these trials utilized a systematic assessment of treatment emergent suicidality using newer rating scales such as the Columbia Suicide Scale. And so they found actually similar rates of treatment emergent suicidality and antidepressants compared to placebo. Older trials used adverse event reporting. So I think it'll be really interesting because future trials will most likely use these suicide-specific measures to see what is the difference between medication and placebo as we continue to conduct more treatment trials. So how do we approach this with teens and families? I take a detailed suicide history, including duration, frequency, and intensity of suicidal thinking, so we can track changes over time. I discuss that there's a small risk of increase in suicidality with antidepressants, but a greater risk of suicide in untreated depression. We have a transparent discussion about safety planning with teen and parent, asking the teen who they will tell if there's an increase in suicidal thinking. Some teens aren't comfortable talking about their feelings with their parents, so we problem solve around ways to keep the parents in the loop, such as a color system where red means that they need additional support. We discuss what that additional support looks like. I also do perspective taking with the teen around how their parents are worried, and this worrying may lead them to hovering around the teen. If the teen can communicate in some way to their parents about how they're feeling, their parents are less likely to hover. So the best way to decrease hovering is to increase communication. So what about placebo response rates? There's been a lot of talk in pediatric mental health about whether or not antidepressants are effective. Part of the reason is because of the placebo response rates. So they vary between 30 to 50%, which is what led people to question the efficacy. So Bridge and colleagues conducted an analysis of 12 studies of antidepressant RCTs in youth and found that the best predictor of high placebo response rates was the number of study sites. They found that studies with more sites recruited participants with less severe illness, and those that had less sites were more likely to have a more unified approach to recruitment, a tendency to recruit those with more severe illness, who will then be more likely to demonstrate response to medication compared to placebo. Of note, some of these studies had 30+ trial sites. So John Walkup took this a little bit further and looked at industry versus NIMH funded studies. And he found, when he analyzed the data, that there were higher placebo response rates in industry funded studies, 50%, and smaller between group differences of 10%. Whereas NIMH funded studies had lower placebo response rates of 30 to 35% and between group differences of 25 to 30%. So what he found was increased rigor in NIMH studies with expert involvement to assure fidelity and accurately identifying participants with psychiatric disorders. And he even suggests calling studies with high placebo response rates and small between group differences as failed trials rather than negative trials due to methodologic issues. So the TAD study is one of these landmark NIMH studies. that guides our treatment in pediatric depression. So it's the treatment of adolescent depression study. The inclusion criteria of 12 to 17-year-old with a major depressive episode of a minimum of 6 weeks with a children's depression rating scale of 45 or more. Active suicidality was excluded. There were 4 arms to the study. Fluoxetine titrated up to 40 milligrams, placebo, cognitive behavioral therapy, and combined treatment. Of note, it was a 12-week study. The last dose increase of fluoxetine was at week 8, and the CBT was a maximum of 15 sessions over 12 weeks. And this study had 13 sites. So the outcome measure was the Children's Depression Rating Scale revised and the Clinical Global Impression Improvement Scale. So response was defined as 1 or 2 on the CGI-I, which is very much improved or improved. So as we see, the highest response rates are combination treatment followed by fluoxetine. So the data show us that for those with moderate to severe depression, combined treatment is the most effective. So in practice, if we have a youth who's had a trial of CBT and there's no benefit, we would suggest adding medication. And if they've only had medication, then we would suggest adding CBT. So in terms of psychotherapy, what's the evidence base? So Robin Weersing and colleagues conducted a review of 42 randomized controlled trials of psychosocial treatments for child and adolescent depression. They wanted to see what therapies reached well-established status. They defined well-established status as evidence of efficacy in multiple trials by independent research teams. So while there were many therapy studies in child depression, none achieved well-established status. For adolescent depression, both cognitive behavioral therapy and interpersonal psychotherapy reached well-established status. We are all familiar with cognitive behavioral therapy. Our thoughts, behaviors, and feelings interact with each other and can improve or maintain depression. So though I primarily see patients for pharmacotherapy, I regularly include therapy skills in session, problem solving with teens or young adults to incorporate behavioral activation into their day or help reframe cognitive distortions. So interpersonal psychotherapy posits that there's a bidirectional interaction between our mood and interpersonal relationships. So if I'm an irritable teen, I'm more likely to get into an argument with my parents. And if I get into an argument with my parents, it's likely to adversely affect my mood. So IPT works on improving interpersonal relationships while decreasing depressive symptoms through improving communication skills, emotion regulation skills, and problem-solving skills. So one of the techniques in IPT is something called the closeness circle and interpersonal inventory, which is really a great way to map out the teen's important relationships in their life and how they impact their mood. So you draw concentric circles on a piece of paper, placing the teen in the center circle, and then ask them to put a lot in the circles who they're closest to. All the important people in their life. So they put whoever they're closest to in the closest circle, and then they work their way out. So the people they're less close to are in the further circle. And then you ask a little bit about how these relationships impact their mood, both positively and negatively. And it's a really great skill to incorporate into session to really understand the important people in a teen's life. Another IPT skill that we use in sessions is mood ratings. We ask for the teen to give us the best, worst, and overall mood of the past week. Then we ask them what they were doing at these points in time. So as a provider, you start seeing patterns of what's helping to improve or worsen the teen's mood. I regularly incorporate IPT techniques into sessions with patients as well, always checking in about social interactions over the past few weeks. It's become part of my review of symptoms with my patients. And again, I problem solve around increasing connections when possible. IPT focuses on patterns of interactions and can be a helpful model to use when there's conflict between teen and parent. IPT skills work on perspective taking and working towards compromise. I had a young adult patient recently tell me about a conversation he had with his parents about his use of video games as a social outlet for him. His parents were used to the sort of old school solitary video game usage, and he explained how it was helping him connect socially because he was playing video games with other people. They weren't aware of this. And so they then had a different understanding of what his video game usage looked like, and it was less likely to cause conflict in the future. So next, I'm going to briefly just talk about a little pilot project I've been working on called Interpersonal Counseling for College Students. I've been collaborating with Alexander Raffaelli on this project. So IPC, Interpersonal Counseling, is a briefer form of IPT. IPC and IPT have the same structure, and they both have 4 areas of focus. So role transitions, which it can be a change in developmental stage, such as teen to young adulthood, or a start of college, an actual change. Disputes, arguments between family members, significant others or roommates. Grief would be the loss of someone. And interpersonal sensitivities is difficulty maintaining or initiating relationships, and looking at what area of focus is really contributing to the depression or helping maintain the depression. So this project is a pilot study we've done looking at a 3 to 6 session model of IPC delivered in college counseling sessions for mild to moderate depression. So as we all know, there's limited resources in college counseling centers. And typically the focus is on severe depression. So the goal is to get these young adults into treatment sooner and receive an evidence-based therapy. So we've actually piloted in a few counseling centers, and then we're working with a colleague, Colleen Conley, to actually adapt it for a group format. So we heard about the evidence base for or the well-established status of IPT and CBT. So what progress have we made in terms of psychotherapy? So this analysis, there's a meta-analysis completed in 2006, and then another one completed in 2020 to look at the effect sizes of psychotherapies. So the 2006 meta-analysis, the psychotherapy showed a modest effect size of 0.34 post-treatment and 0.28 at follow-up assessment. So the current meta-analysis included randomized controlled trials as well as dissertations, and they included IPT and CBT since they were well-established interventions, CBT plus, so if they added parenting, and behavioral and non-behavioral treatments as long as they had a clear mechanism of change. So it was 55 RCTs. So they actually found pretty similar results to the prior meta-analysis. So mean treatment effect size was 0.36. No difference between the two analyses despite an increase of 20 studies. Effects were smaller when compared to usual care as opposed to waitlist control, slightly larger effects for IPT than CBT, and really highlighted the need for relapse prevention sessions. So the authors sort of say, what might we think about doing in the future? So they suggest considering a transdiagnostic approach to therapy, since youth tend to present with comorbidities, and they talk about something called the MATCH program, which is the modular approach to therapy for children with anxiety, depression, trauma, or conduct problems. And it's sort of an interesting idea. It uses a decision flowchart to decide on modules. So it's a flexible approach to evidence-based therapy. It's a little more flexible than the standard manuals that we're used to. They also suggest considering personalized treatment, which I will talk about a little bit later. So I would be remiss if I, of course, didn't include a few words on social media use and adolescent depression. As many are probably aware, it's more nuanced than does social media lead to adolescent depression, though that's the question I'm typically asked. I think what we're finding, at least in the current state, is that it's not use per se, but type and quality of use. So investment in use, how important social media is to the teen, that can then impact their mood. Social comparisons are also associated with depressive symptoms. If teens are looking at Instagram or other social media sites and comparing themselves to the idealized version of others, that is also associated with depression. Public use, updating one's status on a profile, and passive use, browsing on social media, are also associated with depression. Whereas private use, messaging others, and active intentional use, interacting with others, can have positive outcomes such as social support. And not surprisingly, having offline or IRL relationships can improve mental health outcomes. I find it's helpful to ask teens about what social media platforms they're using and how they use it. And in keeping with incorporation of IPT skills in visits, I ask those who are struggling with social media use for them to track their mood when they use social media and when they don't. And based on this mood tracking, I've actually had teens delete or limit social media use when they are aware of the impact on their mood. While teens may not be receptive to blanket statements about social media use, if we help increase their awareness for the impact on their mood, we may see change. So I presented an overview of medication and therapy treatment for adolescent depression. And thinking about how to disseminate best practices, I wanted to briefly discuss dissemination into primary care settings, which I'm sure this audience is well acquainted with. We know the majority of youth with depression do not receive evidence-based care. So I wanted to just touch on this study called Reaching Out to Adolescents in Distress, led by Laura Richardson at University of Washington. So this study recruited 13 to 17-year-olds from pediatric and family medicine clinics who either had an elevated PHQ or a case heads assessment or a second elevated PHQ and an elevated children's depression rating scale. So they were either randomized to intervention or usual care. The intervention group had depression care managers who provided education and engagement sessions. They actively educated about depression for the teen and the parent, and they encouraged participation by both. And then they helped them decide on the treatment, medication, brave CBT, or both. And they checked in pretty frequently initially and then monthly later on. And importantly, if there was no improvement between weeks, between weeks 4 and 8, they would then make a change. So they would either increase the med dose, change the med, add CBT, or add medication if it was CBT alone. The usual care group were identified as having depression and encouraged to follow up for depression treatment, and they had access to treatment. So what they found was in the intervention group, they had a greater decrease in the children's depression rating scale, and they were also more likely to have depression response and achieve remission. And so what I think is really interesting is that the usual care group were identified and had access to care, yet few actually took advantage of the access to care. So it really shows that the engagement strategies were important. Screening and access alone is insufficient. So I think it was really interesting highlighting the importance of engagement strategies and how can we incorporate those into our models of care. So next I'm going to talk about treatment-resistant depression. And I often sort of wonder, what is our definition of treatment-resistant depression? It's at minimum one failed antidepressant trial at an adequate dose for an adequate duration of time. But that's pretty much all we can agree on. So, and what do we do with treatment-resistant depression? What's our algorithm? How do we make decisions? So the treatment of SSRI-resistant depression in adolescent study, or the TORDIA study, helps guide our treatment, at least initially. So 40% of adolescents don't respond to initial depression treatment. And what should be our next step? So these youth had to have failed an SSRI trial, which was a minimum of 8 weeks and 4 weeks at the equivalent of 40 milligrams of fluoxetine. A children's depression rating scale of a minimum of 40, and it's a clinical global impression severity score of moderate severity. There were 4 arms, switched to another SSRI, maximum dose of 40 milligrams, and the mean was 34 milligrams. And it was either citalopram or fluoxetine. Switched to an SNRI, venlafaxine, maximum dose of 225 milligrams, with a mean of 205. Switched to another SSRI plus CBT, or switched to venlafaxine plus CBT. And CBT was a max of 12 sessions, and the mean was 8 sessions. So again, we see combined treatment is effective. So CBT, though, plus either med has a higher response rate compared to med switch alone. But there was no difference in the switch to SSRI or SNRI, but there were more side effects with venlafaxine. So I actually use this in clinical practice to guide my decision that if I have a teen who's failed one SSRI trial, I try another one before switching to an SNRI. In terms of sort of how to treat partially responded depression, we don't really have a lot of data to tell us what to do. So I typically, if teens have a partial response, I'll augment with bupropion. It has the lowest side effect burden unless there's significant suicidality. And though I've seen a lot of teens with comorbid anxiety, I still find bupropion to be helpful for augmenting for depression. If a teen has significant suicidality, I augment with lithium since there's some suicide protective qualities. I've also found lamotrigine to be a helpful augmenting agent. I'm less likely to use atypical antipsychotics given the metabolic effects. I usually have a detailed discussion with the parent and teen about all treatment strategies, including side effects, reasons to choose or perhaps not choose a medicine, and then we collaboratively decide on the medication. If there's no response to initial SSRI, I follow the TORDIA guidelines. If there's no response to a second SSRI, then I will use a non-SSRI. For individuals who failed several antidepressant trials, I've actually had luck with nortriptyline, though the data on efficacy is really not really prevalent in the pediatric world for depression. So another treatment under investigation for treatment-resistant depression in adolescents is TMS, which is FDA approved for adult depression. This study was led by Paul Corkin and colleagues. It was a randomized sham-controlled trial. It was 13 sites, individuals ages 12 to 21 with treatment-resistant depression, defined as 1 to 4 failed antidepressant trials. 30 sessions over 6 weeks, and the Hamilton Depression Scale was the primary outcome measure. So the results, both groups had improvement in depressive symptoms, and there was no difference between groups. It was well tolerated. The most common TMS side effect was headache and nausea. So the authors or researchers sort of were thinking about next steps or why this might be, and they thought that perhaps adolescents may need more pulses or sessions, a different dosing strategy, or different coil localization techniques. There was an open label feasibility theta burst simulation study with 20 participants, ages 16 to 24, 10 sessions over 2 weeks. And this was completed a few years ago. There was significant reduction in depressive symptoms. It was feasible and well tolerated. So though it was open label, it could lead to more treatment trials demonstrating efficacy, which could lead to FDA approval, which would mean that perhaps we could get insurance reimbursement, which is a barrier currently for teens in our area to receive TMS. So ECT is something else that we think about for treatment-resistant depression in youth. We don't necessarily have great guidelines on when it's indicated, but this study looked at different ages, whether there is different side effect profile or different benefit. So this was a single center retrospective cohort study of patients ages 16 to 30 receiving ECT over a year at one site. They received initially right unilateral ultra-brief pulse ECT, and they wanted to see if there were, differences in responses by age. So there were 424 patients. They had to have baseline data. The depression was, they used the QIDS, and the cognition was assessed by the MoCA. 5% adolescents, 62% young adults, and 33% adults, 64% of whom had depression. So they found that there was an overall improvement in depression symptoms. So sorry, they all had severe depression at baseline. So there was an overall improvement in depressive symptoms and self-reported mental health. They used the basis 24 to assess that. And there was a 1-point reduction in the MoCA, but age was not a predictor of any of these outcomes. And there was no long-term follow-up, though, to see if cognitive changes dissipated. But it was, I thought, an interesting study that highlighted that it, is effective in the adolescent population and young adult population, and that the side effects are not worse based on age. And I know at different institutions, they have different protocols. At our institution, we have to have 2 independent child and adolescent psychiatrists agree that ECT is indicated and the best course of action. So another intervention under study is ketamine. So S-ketamine is FDA approved for adults. It's been shown to decrease depression and suicidality. This study was led by Jen Dwyer and colleagues, and it was an IV ketamine study. It's a randomized controlled trial for treatment-resistant depression in 13 to 17-year-olds. So it was a crossover design, single infusion of ketamine or midazolam and the other compound 2 weeks later. They were required to have failed at least 1 antidepressant, but on average had failed 2 trials with an average duration of 21-week depressive episode. Imminent suicidality was an exclusion. They had to have a minimum CDRS score, and the Montgomery-Åsberg Depression Scale was the primary outcome measure. So they found an effect size of 0.78 24 hours after single infusion of ketamine, and the benefits lasted for 2 weeks. The most prominent symptom was transient dissociative symptoms. There is an S-ketamine trial that's been completed, but we're awaiting the results. So as I mentioned earlier, personalized treatment may be an avenue toward more effective treatments for adolescent depression. These are a few examples. One study used machine learning methods to predict treatment response from the TADS data set. So looking at treatment response to fluoxetine, CBT, or combined treatment. So interestingly, the model identified variables that had not been previously identified as TADS moderators, such as psychosomatic symptoms, number of missed school days, view of self, treatment expectations, and attention problems, all of which determine the teen's response to a specific treatment. The next study also used the TADS data set and looked at growth mixture modeling. They found 3 groups of adolescents: high severity with early improvement, high severity with limited change, moderate severity with late improvement. And they identified baseline predictors of depression treatment change for each group, such as number of comorbidities, hopelessness, and cognitive distortions. So the last one is actually a personalized depression prevention treatment. So they looked at using baseline assessments to assign therapy intervention. It was a matched, non-matched design. So teens with high cognitive risk and low interpersonal risk received CBT. High interpersonal risk and low cognitive risk received IPT. And then the non-match was high cognitive risk receiving IPT and high interpersonal risk receiving CBT. Hopefully I got that right when I said that. So what they found was that matched teens had significantly greater increases in depressive symptoms, so significantly greater decreases in depressive symptoms than non-matched. So using those baseline assessments to tailor the treatment was really beneficial. So based on these and other similar studies, collecting more and specialized data at baseline before starting treatment could result in more individualized treatment and improved outcomes for youth with depression. So another avenue of personalized treatment is pharmacokinetics, which we're also probably all familiar with. So this study looked at pharmacogenetic informed treatment versus treatment as usual. in 176 teens aged 13 to 18 with moderate to severe depression. Readers, teens, and parents were blind to treatment. Interestingly, they found that there was no difference between either group at 8 weeks or 6 months in follow-up, in symptom improvement, side effect, or satisfaction. But SSRIs were prescribed 67% for the GeneSight group and 82% for the treatment as usual group. So I think this highlights that there's still a gap in research for whom these tests are most useful. And in clinic, I think it's really important to manage expectations for the family. We're familiar with the sort of green, yellow, and red medications, and that we really need to educate that green doesn't mean the most effective, and that we can use it to guide our choice, but not drive it. So I presented evidence for pharmacotherapy and psychotherapy for adolescent depression, including the approach to treatment-resistant depression. So we know 40% of youth do not respond to the first antidepressant trial. So partly one of my questions is, what is the definition of treatment-resistant depression? I know clinically that 1 to 2 failed trials versus 5 failed trials is not comparable. Should we have a treatment-resistant depression classification system with stages or levels, accounting for non-response to antidepressants and evidence-based psychotherapy? There's a Dutch measure for quantification of treatment-resistant depression, which includes other factors such as measures of functional impairment, presence of comorbid anxiety, or psychosocial stressors, all of which can influence the course of depression treatment. When do we recommend ECT? I typically will try many trials of medicine before ECT, knowing we're going to lose a semester of college or part of a school year. Is that the right choice? I don't know. What about ketamine? When would we recommend this? Once we have more data. What's the durability of its effectiveness? Anecdotally, I have a few young adults who've received multiple ketamine treatments over time, and the efficacy is waning. How do we personalize treatment? How do we identify more homogeneous groups? What should our models of care look like? How do we develop more integrated care models to extend the reach of depression care, including engagement strategies? Should we treat all parents if indicated? We know not treating parents affects outcomes for youth, and treating parents improves outcomes. So what would those models of care look like? So these are sort of things I routinely think about in my clinical practice. So that is the end of my presentation, and I want to see if there's any questions.
Thank you, Dr. Miller. What a path through multiple domains of adolescent depression. Very informative. I think this raises many questions. One that, and we've got plenty of time, so I encourage people to write in with questions, and several have come in already. One that I was wondering about, which a colleague wrote in about, what is a common or difficult sort of problem to differentiate from? And more specifically, as a participant wrote in, what about like early onset or symptoms of borderline personality disorder? Is that a scenario you see with trying to differentiate? Is that a challenge? Can you comment on that?
So that's an interesting question. So as a child psychiatrist, I've always been taught we do not, diagnose personality disorders in adolescents. Do we see some traits? Perhaps, right? So that's one thing I'll mention. I also always take the approach that when you have an untreated mood disorder, a lot of teens have dysregulated emotions and may have a lot of black and white thinking and may not sort of be their best selves. So I would want to fully treat the depression before seeing what temperamental vulnerabilities are sort of left. And then we may prevent the onset of a personality disorder if we can pick up on those sort of temperamental vulnerabilities, do a lot of DBT. So maybe we can change that trajectory, would be my hope.
That's it. That's interesting. Yeah, thanks for that comment. As I invite others to continue to write in with questions or comments, something else I was wondering about for college age students. I mean, you mentioned that population a couple of times. I wonder, as a clinician, what might I look at adolescent child treatment guidelines, evidence, adult treatment guidelines, blending the two? What do we do?
I do think that's a great question. Since I'm a lot of the I see young adults who come as young adults. I also see teens that just sort of stay into young adulthood. So I think it is kind of a melding. And I typically I really do the kind of one SSRI, second SSRI, even for the young adults, which my adult colleagues may not agree with, just because that's sort of my standard approach. But I don't think it's so different. I optimize the medicines. I use the same augmentation strategies. I might be able to titrate a little bit quicker because I'm less worried about like activation or something. But it's a pretty similar sort of augmentation strategy and approach. And we even we include parents as much as possible with young adult treatment as well. We just think everyone being on the same page is really valuable.
It's an interesting point involving parents, for example. How much, if you had to estimate, like how much information do you get from clinical information from the adolescent versus family members? Does it change over the course of several months of treatment?
It depends on the patient. So we have some teens who are a little bit more insightful and aware, and some that just are not aware of any changes. So it's really nice to get the objective data where the parents actually they come out of their room a lot more. Actually, they interact more. We have more family dinners. Other teens are a little bit more insightful and will say, I've noticed that I'm out of my room more and interacting. So it really, I think, depends on the teen that we're seeing, but you get a good sense if you kind of do enough sessions with both of them, you'll get a sense to see how important the information from the parent is.
Thank you. Here's something you might not hear from family, you might hear directly from the patient about regarding cannabis use.
Yeah.
Are there specific interventions for adolescents with depression who are using cannabis regularly? Do treatments change? What do you see?
So I like to say I'm very blessed that I work in an academic center. So if I have someone who's substance dependent on marijuana, I have a colleague who specializes in that. So we have people who, if they're dependent, we really try to transfer them to the substance use clinic because they have more skills than we do at treating sort of more co-occurring disorders. That being said, we aggressively treat the mood. We do a lot of education about the impact of marijuana on the mood, the impact on perhaps the medicines not being as effective, and really what is it that you're getting out of the marijuana use? And if it's really to improve your mood, we have other ways to do that. Is there an negative impact in using the medication? What are the positives? Is it causing conflict with your parents? Is it causing you to be more amotivated? So really kind of doing a deep dive into it and see if we can get them to buy into even decreasing in frequency. We've had patients who will say, well, I'll just use on the weekends, with my friends. And then over time, maybe they'll decrease that use.
Thank you. Now, I'd like to encourage participants write in with any additional questions, comments, and while that's happening, very interesting. I mean, you had developed this expertise in clinical and research related to interpersonal psychotherapy. You mentioned interpersonal counseling. Why do you? I mean, that meta-analysis you presented showed IPT had greater effect compared to CBT.
It's a little bit. I mean, I don't want to make it CBT is still effective.
Yeah. I mean, do you think is it related to influence of peers in adolescence? Do you think or is that not why?
I think, and I don't remember how many studies there were of each, but I think most teens like talking about relationships, with the caveat that every now and then I have teens say, I don't want to talk about my relationships. And I'm like, okay, what do you want to talk about? But most of them actually like talking about it. They like talking about their peers. You can sometimes get them to buy into working on their relationship with their parent if you can show them that it's really problematic, your mood could be better, or some teens don't want to be getting into their arguments with their parents. So really looking at the impact and trying to get them to buy into it is sometimes a little bit easier than other modalities.
That's interesting. It can make psychotherapy maybe move along if it's something they like talking about. It's interesting.
Yeah, I think it resonates with a lot of teens.
Yeah. One other point, I mean, there's a couple of questions have come in about concurrent clinical problems, like we talked about with cannabis. This one's related to trauma exposure. Specific considerations, if there's either the person's currently experiencing trauma or past experience with trauma.
So I think we try to meet the person where they're at. So a lot of individuals don't want they're not ready to, they don't want to do trauma work, they're willing to work on other skills first. So it's really like sometimes we've done either DBT or CBT, whatever approach, and then just to help their depression improve without actually doing trauma work. And sometimes they're ready to do the trauma work. So I think it really is, you know, we just have a discussion with the patient to see what they're sort of ready or able to do. And then focus the work based on that.
Does it influence medication choice?
I mean, usually it would be, if I were seeing them, they'd have comorbid depression or anxiety anyway. So I would start an SSRI. If there's a lot of nightmares, sometimes we have benefit with prazosin, but it's really, it's a lot to do, I think, with therapy and some with medication.
One of the questions came in about, now you mentioned about treatment-resistant depression, and it means many things. So maybe I'll pose the question, but you know, respond as you will, about being more specific with medication choices when there's a treatment-resistant depression adolescent that you're seeing. Maybe it's not possible to be more specific, because maybe it's just one failed trial, maybe it's 5 failed trials, like you said. That's a very different clinical scenario. But I guess if I was to turn this into a more, maybe make it more specific, is there a tip? I mean, you mentioned a couple of augmentation strategies that you'll try. Is bupropion typically first, or are there yeah?
So if I have a partial response to an SSRI, and there's no like suicidality, there's just sort of moderate depression, I usually just go with bupropion, because it can work really well, and it just doesn't have as many side effects. I mean, you can have some activation and it can worsen anxiety, but all in all, I've had pretty good benefit. If they're really suicidal, I really just start lithium. I like lamotrigine. It takes longer, so it really depends on what my timeline is to get them to an adequate dose. So it kind of just depends on how severe the illness is. And I really actually go through all of the pros and cons. And sometimes the teen will say, "Oh, I want to do the lithium." Like, that sounds, you know, like we'll just go through everything. And I rarely, but I'll sometimes have teens where I'll augment with mirtazapine if they're having trouble sleeping and they might have some like eating issues, some restrictive eating issues that might help us. So I try to tailor it sometimes to what else is going on, but it's really, I sort of kind of do a gestalt and then talk to the parent and the teen, go through all the sort of information, and then see where they're at. And then, yeah. Which is probably why we need a, more systematic way of doing it.
Well, it's interesting. I mean, I was here describing that. I'm just thinking what proportion of medication treatment decisions that you face are kind of off-label, given that there's so few indications.
A lot of them, most of them.
Yeah, it's interesting.
Yeah.
Another question, Dr. Miller, about concurrent problems, this time with eating disorders.
Yeah.
Can you comment on that? Maybe assessment or the effectiveness of medication treatments in these individuals?
So again, I'm blessed to work at an academic center, so I do have colleagues who are experts. So I have a colleague who sometimes will just do an assessment for us, and then we might have like a specific therapist working on kind of meal planning and calorie, meeting caloric targets, and then we'll work on the anxiety and depression. If they have, anorexia, then we'll probably refer them. If it's kind of just, I have a couple individuals who don't have anorexia, but are having some eating issues. So we might just bring nutrition in to help with some like education and guidance. And then we will work on sort of a little bit of behavioral plans with them. Binge eating, we would look at what are the triggers. There's a lot of times it's emotional, right? It's mood related. So we might try to increase awareness of what's your mood when you're binging, what's your mood after, to try to help with that. And then bulimia, depending upon the severity, we would either try to manage that ourselves or refer it to an expert. If there's kind of multiple, binges per week, then that's probably something that the eating disorder specialist should. But if it's, occasional, we work with that too. Again, it's kind of like self-injurious behavior, all of the sort of maladaptive coping skills, like what's your mood before, what's it after, what can we do instead of engaging in this behavior, that kind of approach.
Thank you. Now, you mentioned we've got about 2 or 3 minutes. So if anyone's got another question, type it in and I could pose it. In the meantime, though, one of the things you mentioned earlier on was sort of the frequency of arguments, disagreements within a family, which maybe as a result of and can contribute to depression. That's many things. I was wondering about family therapy. I mean, is that part of, is that a usual option? Is that infrequent? What about that?
So we try to really have the teen as sort of the primary agent of change, if at all possible. And so working with the teen to work on the skills to then use with the parents. We do bring parents into session if the teen's having a little bit of trouble utilizing the skill. Infrequently, we will find someone who needs to sort of be more impartial, because if the teen is our sort of identified patient, then we sometimes need to find a separate person to do the family therapy if it's really like the dynamics that we just can't make movement on. But we usually try to work with the teen specifically, and then the therapist will have sort of family therapy sessions where they need to kind of discuss specific approaches or plans with safety planning. I mean, it really depends. We incorporate that as needed. And I meet with the parents most of the time as well, just to do a check-in about kind of how treatment's going and to make sure we're all on the same page about the medication plan.
I see. And that's with the teenager present, or?
It's usually, I have a few teens who do not want to be in the same room, which is something we work on, right? But most of the time it's everyone together, just to make sure, this is what I'm going to tell your parent. Are you okay with that? This is what we're going to talk about. Transparent discussion.
Yeah. Okay. Well, we've got just about a minute left, and I want to tell participants, I didn't mention this in the introduction. If anybody wants to read a highlighted, or not a highlight, but a summary of this in an article form, it was published. Dr. Miller published a review of this topic, adolescent young adult depression, in the New England Journal of Medicine, I don't know, about 6 months ago or so, which goes through many of these aspects. Is a very good reference. And with the remaining time, Dr. Miller, I want to thank you for joining us today for Grand Rounds and presenting on this topic here at UW.
Thank you for having me.
All right. Well, we're just at 1 o'clock, and with that, we'll end Grand Rounds today. Thank you.
Thank you. Bye.